that you're a medical doctor practicing in Zambia at the National Heart Hospital. But can you tell us a little bit about your training? Where did you train? Did you train in Zambia as well?
Oh, yes. Thank you so much for that question, Peñas. So, yes, I'm currently working. I'm in a hospital right now. I'm covering a night shift, and I'll probably be done by 8 in the morning. Yeah, so I did train locally here in Zambia at the University of Zambia. The University of Zambia is the highest learning institution here in Zambia, and they do offer a medical program, of course, alongside other programs. And of course, there are different universities here in Zambia that are offering the same medical program. But of course, being the highest learning institution, the University of Zambia really sets a standard in terms of medical training. So the medical degree program itself runs for a period of 7 years currently, although they're trying to restructure the program into 6 years. This is because they realize that the first 2 years, which were mostly focusing on basic sciences, they felt they could try to merge the first 2 years and make it 1 year, and then, of course, maintain the remaining 5 years to make it 6 years. So currently, the program that I did actually ran for a period of 7 years. The first 4 years mostly focused on basic sciences, of course, with 2 years being spent at the main campus of the university, and then the remaining 5 years was spent at the other campus of the university, which is the University Teaching Hospital. So that's basically around about the training. And so the training is quite intense at the University of Zambia. It's quite competitive because it's not everyone that can eventually do the course. So the university gets to admit a huge number of young people, for example, 2,000 at times. And from that 2,000, they may only require about 80 young people. So they definitely do get the best 80 from that particular year. And so it's quite competitive, and it's quite demanding. You really have to put in your best because everyone that you see around you at that particular point is a competitor. The person is determining whether they're going to do the program or whether they're going to be channeled into a different program. So most young people go with a vision or with the dream of becoming doctors, but later on, others end up becoming biomedical scientists, others end up becoming nurses, becoming pharmacists. So basically, that's the method that's used by the university to actually come up with the best. And so basically, that's what happens here in Zambia. Then, of course, when you actually cross over to the other campus, you do start the first 2 years with basic sciences, you do some basic anatomy, and that's where we now do also neuroscience in our 4th year. Yeah, so neuroscience, we do it in our 4th year. Though I think on neuroscience, I must mention that neuroscience is the biggest weakness of medical students here in Zambia. You find that probably the highest, maybe we have a B, that would be the highest grade that someone would get in the class. So the foundation really is quite poor when it comes to neuroscience, and it's evident even amongst the practicing specialists. I think we graduated our first neurologist here in Zambia, I think about 2 years ago, the first ever neurologist here in Zambia, which should show you that neuroscience is really lagging. The foundation is quite poor, and so most physicians don't think of specializing in things like neurology and neurosurgery. And so that's where we are. And so after we do the neuroscience, then we now cross over to the clinical years, which are 3 years in total: 5th year, 6th year, and 7th year. So 5th year is basically just about clerkship. You're being introduced to the hospital, the environment, taking histories, doing physical examinations, coming up with diagnosis. And then 6th year is mostly community work and field work, and as well as research. So the research component is incorporated in 6th year. Though I must also mention that the research component is not taken so seriously by most students. And I feel this has a very big impact even in how we are handling most of our public health emergencies. And the COVID-19 pandemic really exposed this aspect because we could not research. We had to rely on interventions from across the globe. We had to rely for interventions from the NHS itself, of course, from the United States. And so it's quite challenging because the foundation in research is quite bad, as well as the foundation in neuroscience specifically is quite bad, I must mention. Then 7th year mostly is about clinical management of cases. After you've had that foundation, you now have to learn how to manage the specific cases themselves as you prepare to get into internship. Then after that, you graduate, of course, with a Bachelor of Medicine and Surgery, in addition to the other degree that you get after doing the first 4 years, which is a Bachelor of Science in Human Biology. Yes, so after you're done with that program, then you now cross over to become an intern like I am. I don't know if I have forgotten anything, Peñas.
Wow, that's a lot. So that's a whole journey, a 7-year journey. Definitely, I'm sure
Yeah.
it's taken its toll on you, but I am more than sure you are happy, and you feel you are contributing to a local agenda to improve the lives of the people in Zambia. And we are very grateful for your service. And definitely the NHS is very grateful as an extension and the support it offers to different governments in Africa. So we are definitely happy that you are rendering this service despite the long career path that you've actually had. You have alluded to
Yeah.
some of the weaknesses in the system. I had noted you had talked about a weakness in terms of training. That's a neuroscience weakness. And then you also talked about a research weakness. And we're going to talk a little bit about these two weaknesses. So, Adele, what do you think? How's the situation? So Adele would like to give us a little bit of a perspective of how in perspective when it comes to neuroscience training, being someone that's specialized in this field. How's training in neuroscience back in England?
I haven't done medical school myself. I have a few friends that are there. And from my understanding, science starts earlier. So for example, they don't have that initial year of a funnel. You do your exam and then you're directly into medical school. And in their second year, they have this course called medical neuroscience. So it is all the medical part of neuroscience. So the generation, development, and all of that. And although very interesting, I think it is a little broad at the beginning. But I haven't done the medical training myself. I know then it can become a specialization later on, and a lot of people take it, to be completely honest. I'm not sure if it's more for the money or for the actual cause, but that is my own personal opinion. Because a neurosurgeon, for example, is a very prized position. But then a lot of people say, oh, it's so complex. And it is very complex, which might actually be why it is a harder subject to teach and to learn back in Zambia. That is my personal experience. You tell me if you have
this is a very interesting thought that Blessings has shared with us, to say that neuroscience is a big challenge. And because of the challenge that students have in their training as medical doctors, for example, the weaknesses that they have in neuroscience trickles down to clinical practice. For somebody that majored in neuroscience, not as a clinician, but someone that majored in neuroscience, what are some of the ins and outs of this program, of a neuroscience program? How can someone thrive in this program? Maybe lessons that medical students could learn while they are in medical school or medical training back in Zambia, as he's mentioned. What do you think are some of the ins and outs?
That's a very interesting question, because I need it myself. So neuroscience is a complex subject, because it regroups so many different aspects of medicine. We're dependent on our nervous system, so it is so broad. It has so many implications. Personally, I love it, so I do not see difficult parts.
Okay.
That is a personal experience. I would say definitely get into it, research papers around it, because papers are so in it. This is a very new field. It is 20-30-year-old. New research is very recent. And so really papers are a better way to better understand it, more than actual clinical terms or clinical papers. For example, if you look at the heart, there are thousands of years of medical history explaining how the heart works. But then you look at the brain and the theories keep evolving. So personally, I think that looking at papers, keeping up with research technologies is really important to better understand neuroscience.
Okay. So Blessings, a lesson that you can tell our medical students back in Zambia that they need to keep abreast with the latest papers when it comes to advances in brain knowledge. So on your side, Blessings, you've also talked about research being very weak. Where do you think the problem lies when it comes to research? What really is
Okay, so I think
why is the program weak when it comes to research?
all right, yeah. So I think when it comes to research, there are quite a number of problems. Firstly, I can maybe start from a student perspective. So, research as a course is actually only taken, for example, by medical students here. For example, I'll give an example in 60th year. So in 60th year, you realize that it's a very free year for most medical students, a time when they want to rest. And so, you put something as important as research in a period when students feel like they have to rest, they'll not take it seriously. And so they'll wait till the last minute to just come and look for data somewhere and probably regurgitate a certain research that was done before and submit and proceed. And then other than that, away from the medical students, I feel like the foundation when it comes to research is quite poor because most students are only introduced to research as they end or as they go towards the end of their programs. For example, pharmacists who are doing their 5-year program, they're only introduced to research in the 5th year. And for nurses who are doing their programs, for example, in 5 years or in 4 years, they're only introduced to research in the final year. So people don't have adequate time to really learn the principles of what research is really about. So that's the first problem when it comes to students. When it comes to a national perspective, there isn't much investment that's channeled towards research in our country. For example, if you even go to certain extents as to look at the national budget itself, you really find nowhere where there's an allocation for research, either in the health sector or anywhere else. Most of our interventions or most of our resources are channeled towards curative treatment, towards curing diseases. We don't really care so much about investing in the preventive aspect. And of course, research, as you will note, falls mostly on the preventive aspect. Because when you research and you have the data, you'll be able to prevent certain occurrences from happening. But that is a weakness on our part. So there's little resources that are channeled towards research. And so from the foundation, you realize that very few people are taking part in research. And even the amongst a few people are taking part in research, you realize that very few of them actually think or probably try to mentor other young people into taking part in research. So those gaps still do exist, especially with regards to resources and regards to the human resource to be able to teach research in universities and schools.
So I see. So it's a challenge in terms of manpower. People are not, there's no mentorship for young students or students training to be part of the workforce, to be researchers. So that's a weak part of training in this context, and it needs to be addressed for us to make progress in terms of clinical outcomes. What do you think is the link? Where does the link lie between clinical outcomes or improved clinical outcomes and research?
All right, thank you very much for that question, Peñas. Actually, wanted to say that, here in Zambia, for example, if someone says, I want to just do public health or I want to just start doing research, those people are considered to be less serious with their lives because they expect that someone who's serious with their lives will probably be thinking of something to do with maybe specialize in a clinical course or just do something with their careers in terms of maybe specializing in something that's probably more meaningful, like maybe in neurology or cardiology or become a surgeon. And so most young people really shy away from that research aspect because of how it has been painted and because of the stigma that comes with you saying you want to actually specialize in research. People will take you like you're not serious. How do you just want to do public health and just start researching? So when you look at clinical outcomes and research, you realize that research actually improves clinical outcomes. The research improves patient treatment in our case, because you realize that I can give a practical example of the COVID-19 pandemic. You realize that for us, we had less information about what the COVID-19 pandemic was. We did not invest in any research whatsoever. And so we had to rely on research that was done outside. So we talk of the vaccines that we're using today. Those vaccines came as a result of other people doing research and finding that this could actually work. So on our end, there was no research whatsoever. So it means that whatever management that we're offering to these COVID patients was just basically based on what we knew at that particular point, just basically based on just trying to calm the situation without actually even treating the virus itself. Just basically about watchful waiting, where you don't know exactly whether what you're doing will work or not. And so there were quite a number of patients who died in that way. But if you look at that aspect of research, had we researched, had we known what exactly the virus was, had we known some of the interventions that we're doing, would have prevented most of those deaths. So really, research is a very important aspect in whatever thing we can think about.
Okay.
If I may ask a question very quickly from my own perspective, could you tell me more about the recruitment of health workforce after being trained? Because, for example, I know that for some European countries, they tend to go to other countries, and there is a very big problem of losing workforce. So if you could just tell me a bit about that for your experience.
All right. Okay. So when it comes to the recruitment, so previously our country was training very few health professionals. And so you find that it was quite easy for the government to absorb those health professionals. But now we have seen that, first of all, the population has grown, because previously I think we're about 10 million, but now we're over close to 20 million now. So the population has almost doubled. There are more young people that are training in health. For example, I'll give you an example of our university. The facilities have remained the same classrooms, but the numbers have almost tripled. And so you realize that the government really has a lot to do. And in our case, as for example, medical doctors, we cannot work in a private facility upon completion. We have to do a mandatory 1 year, 6 months of internship. The same also goes with our pharmacists. They also have to do a mandatory internship. So you realize that the government is no longer in a capacity to absorb the workforce that is being graduated by the country. And so there are quite a number of young people who have studied, who are doing nothing at the moment. We have quite a number of young people who have studied medicine, medical doctors, they're not working at the moment. Nurses, it's even worse. Pharmacists, worse. Physiotherapists, it's even worse. So we have quite a number of young people who are not doing anything at the moment. And so most of these young people are actually thinking of actually even going outside the country. Yes, but as I said, for medical doctors, it's quite tricky because it's mandatory that you have to be employed by the government before you could work anywhere else and before you could get your full practicing license. So for the medical doctors, most of them have waited, but immediately they get their licenses, most of them are resorting to either go outside the country or probably just start working in a non-governmental organization. So there are quite a number of medical doctors and most health practitioners here in our country no longer want to practice. Most of them are looking for greener pastures elsewhere. So that is the situation that we're in with regards to the recruitment.
So definitely challenges when it comes to recruitment, but we can't solely base it on, we know that resource allocation is difficult, and with different economies, definitely there are challenges that come about when it comes to recruitment. But then an interesting point that you mentioned was that some people get employed, some don't. So then it's as a young person, what would you say, a person training as a healthcare worker, what can you do to make yourself a little bit more competitive to grasp opportunities that so that you do not necessarily have to wait for the government to employ you? I know that the government has always encouraged young people to reach out and actualize their potential. So what are some of the things that healthcare workers can do to better themselves in terms of being more competitive in the job market, now that you said that there's a problem with recruitment?
All right. Yeah, so there's quite a lot that healthcare workers can do. Firstly, they don't need to have a narrow vision. They need to have a broader vision, because the world has become very competitive now. And the world, these days, mostly the world is looking for skills. What can you offer? Yes, you have studied medicine, you're quite intelligent, you're a pharmacist. Yes, you have done that, but what else are you bringing to the table? And so this is where components like research come in. Are you able to research? Are you able to analyze data? What else are you bringing to the table apart from what you have studied? And so one thing that I would really advise healthcare workers to do is look at different things. You could do very minor programs. For example, you could acquire a skill in graphic designing. You could acquire a skill in digital marketing. So all these skills have become very important, and young people are actually able to make money just from these skills. But what has happened now is that most of us have a narrow vision. Because I'm a doctor, I have to work in a hospital. Because I'm a pharmacist, I have to be giving out drugs. But there's really so much that you can do in your capacity. And that's why, personally, I've taken it upon myself to try to explore other areas. And from what I've seen, for example, I went to Ghana, I went to Rwanda, I've been to Malawi, actually, I've been to Tanzania. And in most of these spaces, I find myself that I'm the only medical doctor. It's because most people in the healthcare sector, most health practitioners don't see these things to be important. For example, certain things like governance, politics, all these things, they really do get to affect how you as a healthcare worker is going to work and how conducive the environment is going to be for you. So you could develop certain skills in leadership. I've attended so many leadership trainings where I've been the only medical doctor, where I've been the only health practitioner in that space. But these are skills that young people can start developing, develop leadership skills, because we are in the 21st century. That's one thing we need to understand. And the problems of the 21st century can only be solved using 21st century skills. And so we should invest in getting these 21st century skills. What the world is looking for now is, can you analyze data? Are you able to, do you have leadership skills? Do you have networking skills? What personal brand have you developed as a healthcare worker? You realize that there's quite a number of healthcare workers who are not on LinkedIn, they're not on Facebook, they're not on Twitter, they're not on Instagram, they're not on anything. So they're not networking, they're not talking to people, they're not sourcing for opportunities. Okay. So this is basically what we need to really focus on as healthcare workers.
Okay. So you're saying healthcare workers need to diversify their skill set, not only to include the skills they have learned while they are in medical school or in healthcare school or pharmacy school, whichever branch of healthcare that they are affiliated to, but then they need to diversify their skills. They need to network more, and that way they can become more competitive in the job market that is currently suffering, definitely not only in Zambia, but across the globe. There is definitely problems with recruitment of healthcare workers across the globe for various reasons, obviously. But students need, or healthcare workers in this case, starting from the point that students need to develop skills, and you have clearly brought out that for us. Can you share some insight when it comes to clinical practice? How's the not specifically for Zambia, you've definitely moved around different places. How's the landscape when it comes to African clinical practice? Is it are most people in the public sector? Are most people in the private sector? How is clinical governance done? How is the governance structure of healthcare? Could you share some insights?
All right. Yeah. So this is quite a broad question, but I'll try to tackle it from all different angles. So firstly, when it comes to the health sector, the challenges that we're facing a lot as a continent, not only in Zambia, but across the globe, is healthcare financing. So healthcare financing really is the biggest challenge. So we realize that in 2001, we have what we call the Abuja Declaration, where all African countries signed to allocate at least 15% of their budget each year towards health. So almost all African countries do not allocate more than 15% to their budgets despite signing to this. This is because of the various challenges that we are faced with as a continent. The poverty levels are quite high, and now we're in a situation where there's so many crises. The Russia-Ukraine war has had its own impact. we have the climate crisis. So very few countries are allocating funds towards the health sector. In our case in Zambia, we allocate almost 8% of our budget towards health. And this 8% has been allocated for the past 3 years or so. So there's really less funds to be able to finance health. And so here in Zambia, for example, we're now moving towards having a national health insurance. So we now have a national health insurance scheme, which is just coming up, though it's not yet up and running, but at least we are getting somewhere, at least just to try to see how we can cater for the less privileged in our communities. So as I said, Zambia has got rural and urban. So when you go to the rural areas, there are quite a number of challenges that are being faced there. For example, people have to walk very long distances to access healthcare services. People have to walk those long distances, and even after walking those long distances, they may not be able to be attended to adequately because we're still facing challenges with drugs as well as medical supplies. And so not only here in Zambia, but even across the globe, we're facing quite a number of challenges with regards to the supply of drugs and medical supplies. So that has been a big challenge, and it's arising from the very fact that we do not have the capacity, or we do not have the finances to be able to finance our health sector. And so this really has been a challenge on our part. So that's basically how the governance is. So the health sector is literally just run by the Ministry of Health, which is provides sort of like an umbrella body, and they're watching over everything to do with health. So we do not have a national health insurance scheme that is up and running. It's just coming up, and we're trying to get lessons from the national health insurance, of course, in America, as well as in the United Kingdom, trying to see how we can copy the best practices, because we have noticed that we are lagging behind so much in terms of the health sector. So when it comes to the clinical practice itself, there are quite a number of challenges that we face. And one of them I highlighted to the very fact that we have facing challenges with drugs and medical supplies, mostly due to the fact that there's not much financing in this sector. So what happens is that most patients, after we see them, we write a prescription for them and they get their drugs from a nearby pharmacy. And so that has been a challenge, especially for those who cannot afford the drugs themselves. And so I noticed that this is quite the same trend also in Ghana, it's quite the same trend in Rwanda, the same trend in Malawi, it's the same trend in Tanzania. So it's really the same trend here on the African continent. So we need to ensure that we provide quality healthcare, because when we talk about universal health coverage, as outlined in the Sustainable Development Goals, where we're talking about ensuring quality health as well as well-being, we need to ensure that the financing itself is on point. We need to ensure that whatever interventions we're putting across are catering for every citizen of the country, whether they're poor and whether they're rich. And so we're trying to bridge that gap. So these are some of the challenges that we're facing. And then, of course, we have our population is growing, and we're still trying to see how we can invest in infrastructure as well as the human resource. So recently, our government recruited 30,000 or 11,000 health workers to try to cushion that effect, because what we saw was health workers were being overworked. Doctors were working for very long hours because there was lack of human resource, pharmacists, the same with physiotherapists. And so we still have to cushion, because when we look at what the World Health Organization says, it says, at least let's have a doctor-to-patient ratio, for example, of 1 to 1,000. But here in Zambia, the doctor-to-patient ratio is 1 to 12,000. So which is quite huge. So most health workers are being overworked. And so we really need the human resource. So the human resource is not a challenge because most young people have been trained, but the challenge comes in when it comes to the financing, because half of our budget alone goes to the wage bill. It goes to paying civil servants. And so the government is really having a challenge to employ more health workers because of this challenge. So human resource is there, but they have not yet been employed. And so we need to see how we can bridge that gap and ensure most people are receiving healthcare services. So I think basically in a nutshell, that's where we are with regards to the health sector.
So finding like more organized, how to organize the people to better talk to each other, to better understand the problem, correct?
Yeah.
Yes.
How do you think that between the sector, for example, a doctor and a pharmacist, is there a good talking or conversation happening, or are there lacks? Like, can they work together?
So that's a very good question. So another thing that we have seen also is, I can say there's quite some disunity in terms of the different health professionals, in that they don't speak mostly with one language. For example, the time we had the recruitment, there was quite some wrangles came up because uh, the numbers differed. For example, the government wanted more nurses because they felt that it would be better to employ more nurses because most hospitals definitely would need a nurse. And they also felt that we could maybe employ less pharmacists and less physiotherapists. So that's really caused a sort of a stir amongst the different health professionals. And so they have not been speaking with one voice, I should say. And so the same also goes even with the training. So you find that you are staying on the same campus, but then most people get to do the courses they're doing out of circumstance and not because they wanted to do the courses themselves. And so you find that there'll always be that bridge in terms of communication. However, I feel we're still making steps in terms of trying to ensure that we bridge this gap. At least we have seen quite a number of collaborations happening between doctors and pharmacists. Quite a number of conferences are being organized that are interprofessional. And currently, the curriculum that is being developed, as I said, we are changing, restructuring our curriculum in terms of training. So there's actually what we call an interprofessional community-based education, where they're taking the different students from different professionals, those who are studying medicine, pharmacy, and they take them in the field, put them in one space, and ensure that they address the problems collectively. And so at least this is promoting some form of collaboration and cooperation, which I feel is going to have a very huge impact in the near future.
Definitely, definitely. So we are very thankful, Blessings, for having you on our program today. But would like to ask you to give a take-home message to all healthcare workers. We love unity, and definitely amid all these challenges, there are strengths. So in conclusion, we would like you to elaborate some of the strengths of the healthcare system, how it's functioning well, and what great things are happening. We know that there has been a decrease in the prevalence of so many diseases on the African continent, and no doubt that's a strength of the system. So what are some of these strengths that you'd like to highlight, and what's the take-home message for all healthcare workers on the African continent?
All right. Yeah, so there has been quite a number of strengths when it comes to the health system. As you may be aware, that the prevalence of certain diseases has greatly reduced. When you talk of HIV, you talk of tuberculosis, the maternal mortality rate has also reduced. Same also goes with the infant mortality rate, the neonatal mortality rate. So all these have been reducing, and this really shows that the system has really been strengthened. So despite having these various challenges that I highlighted before, there are quite a number of strengths that we have seen. In that, at least we have seen quite a number of specialists. At least the number of specialists has been increasing overall in our country. At least we have more neurosurgeons now, we have more neurologists, we have more practicing specialists, and we've also seen quite a number of people venturing into public health and ensuring that they develop strategies that are going to combat certain diseases and certain public health emergencies. So, I can say we have strengthened our ability to be able to handle some of these emergencies. And this has stemmed from the very fact that at least we have experienced, for example, the COVID-19 pandemic, which has taught us so many things. And before that, here in Zambia, we had a cholera outbreak. And so that also strengthened. So I believe that these challenges have only strengthened us because they have helped us do a very good SWOT analysis. They have helped us analyze our strengths, our weaknesses, opportunities, and some of the threats that lay ahead. And of course, even the training itself, despite us having an increased number of students, but the human resources remain the same, what we have seen is that we have seen quite a number of medical schools being opened in Zambia and even just across the African continent. And this has really been helpful because at least we have more young people training to become health practitioners and to work in these hospitals, which is what we needed, because what we needed was a human resource. So I've seen the human resource being trained, and so this has been a strength on our end. Then, of course, even with the other interventions to finance our healthcare, which we have seen, the health insurance itself has been positive, and I can attest to the fact that at least in the hospitals and even in the hospital I'm working in right now, there are quite a number of people coming from very poor backgrounds who have been able to access certain diagnostic services. For example, a CT scan is quite expensive here, but we've seen that they've been able to access that or that diagnostic or test, despite them coming from a very poor or average background. So these are some of the strengths that I can highlight to. We have constructed more hospitals, and at least we have cushioned the impact, or we have lessened the distance that people have to walk to access health services. So those have been some of our strengths. And the takeaway message really is that most of the problems that we're facing as a health sector can only be solved when we unite. Problems are inevitable, but we must be inevitable solutions to the inevitable problems within our sector. And those can only come if we collaborate. I believe that multidisciplinary collaboration will really go a long way in having us solve some of the challenges that we are facing. We cannot develop in isolation. We definitely cannot develop in isolation. Even when patients come through, for example, in a hospital setting, it requires a collaborative effort for us to be able to treat that patient and for us to be able to cure that particular disease. The same also goes in the public health space. There are so many challenges that we're facing. For example, with regards to COVID, COVID required a collaborative effort of the scientists who had to do research and develop the vaccine. Required also the public health specialists who had to ensure that the vaccine is really taken across different parts of the country, different parts of the globe. And of course, the health practitioners themselves who had to ensure that the vaccine is actually administered to the patients themselves. So we're able to see this collaborative effort. And I believe if we strengthen our unity, we'll be able to address most of the challenges that we're facing as healthcare workers.
Thank you so much. That's a very strong take-home message coming through from Zambia, from Dr. Blessings Kasenge, a junior resident medical doctor at the National Heart Hospital in Lusaka. We are grateful for having you on our program, and from the Health Careers Live team, from Adele and myself, we are very happy with you, and please continue to support the healthcare workforce in Zambia and indeed on the African continent. From Health Careers Live, see you next time.
All right, thank you.
Greetings, everybody. Welcome to Health Careers Live Africa, the first of its kind. Would like to say thank you to the NHS for supporting this event. So the NHS Health Education England Global Department has been responsible for supporting and inspiring our work. Together, we are learning globally and acting locally. Today marks a new chapter in supporting global knowledge exchange and supporting health and well-being at scale. So we're indeed grateful for the NHS England support towards Health Careers Live Africa. With me are three panelists. They will introduce themselves, and we are happy to have each one of them take time from their schedules to share different dimensions about how we can actually build skills amongst our own African students. So our first panelist is Harriet. Can you please introduce yourself?
Right. Greetings, everybody. So my name is Harriet Peter, and I'm a medical doctor by background. I'm a researcher, and I did my undergraduate education in Tanzania. So I'm originally from Tanzania, and I'm currently pursuing my Master's of Science in Global Health at the University of Bergen, Norway. I am happy to share my perspectives in this forum, and I also look forward to learn. Thank you.
Thank you very much, Harriet. Our next panelist is Kastori.
Hi, everyone. My name is Kastori Munishi. I'm currently a master's candidate at the University of Bergen. but originally I'm from Tanzania, and I did my bachelor's degree in pharmacy. And I'm excited to be here and share with the world the little I know. Yeah.
Thank you so much, Kastori. And finally, we have Adele.
Hello, everybody. Great to be here. My name is Adele. I am currently doing my master's in neuroscience here in the UK. My tertiary education has all been in the UK, and I did my high school in China. I am more here as a non-African person that didn't develop their skill in Africa to compare and contrast.
So thank you very much, Adele. And finally, my name is Peñas. I'm a medical doctor. I'm from Zambia, and I'm here to moderate this session. I'm part of this initiative called Health Careers Live, and it's the first of its kind in Africa. And so today we want to take some time to talk about how African students, especially those that are in tertiary learning institutions, how such students can build skills that they are going to use in tertiary education and post their tertiary education. We're also going to talk about some of the challenges that such students or African students face as they endeavor to build skills that they are going to use in their lifetime and in their careers. Yes, we're happy to have this very first Health Careers Live session focused on Africa. So, considering all things, Harriet, we are talking about skills. What are some of the skills that you think are necessary or is necessary as a medical doctor? What skills are necessary for medical students to build while they're in medical school that they can take forward, other than the obvious clinical skills that they're already learning as part of their coursework?
Right. Thanks, Penis, for the question. I'll actually respond based on my personal experience.
Sure.
And I think the very first and foremost, I think, we need a diverse number of skills, because the world is evolving and it's not just about clinicals, but medicine is not just about clinicals. There's a lot of other skills that we can apply in the field of health, that we can, that it's just as important to start, getting to learn these skills since when you are students. And to do that, I think it's important for medical or health students to first be open-minded. By open-minded, I mean that most of the health students or students in health and allied sciences, particularly pharmacy, medicine, spend a little bit longer in school. And other than getting the skills, the basics knowledge that you're taught in class, understanding the pharmacologies, the medicines, how to treat and handle patients, there is still another aspect. There is still other side of things that are, maybe they're just partly taught in class. For instance, research skills, innovation in health. So these are probably not given a lot of emphasis during our training, but they're very essential and very applicable in terms of applying them when you're still undergraduate students, but also further in our careers. So being open-minded to grabbing these skills, to attending different trainings, different seminars, networkings, that will actually help us to build these skills is one important aspect that will help us also see the other part of the world outside the clinical medicine or the clinical perspective. So I think it's good that we are, as medical students or as students in health and allied sciences, we have our eyes open to explore all other possibilities beyond our training. So, yeah.
It's very, very true. Kastori, so Harriet has alluded to research skills. What do you think are some of these actual research skills that students can build? So Harriet has given us a holistic picture of what is needed as students, or for students to a holistic picture of things needed by students to carry forward. What do you think? What are some of the skills that they can actually build? What are these research skills that they can easily build?
Well, there are many, and do not only apply for research, they apply for many things. The first one will be writing skills. It's not mostly of our universities, but in Africa, there is not much insistence in writing. That's why there are some students who are struggling like to come up with a write-up, even as simple like to write a motivation letter onto something. So I think there needs to be a good focus in helping students to develop good writing skills. And then there is communication skills. Students, whenever you do research, you need to be able to communicate your findings. Writing is part of communicating research findings, but communication in general, including speaking skills, listening skills, I think there needs more focus in that, because most of the students, they get solid content, but they how to share it, put it forward to the world is really missing. But also data analysis is important in research, but also understanding the whole research methodology in general, for that matter, like how to do a research, design a study, conceptualize the problem, all those kinds. But that is taught in class. But the gap, I would say, is that it's more theoretical. Students do not have enough time to engage in research activities unless some students who are really open-minded, they attend these conferences. Mm-hmm. So I think universities should offer more time or encourage their students to attend conferences even when they're still at an undergrad level, because when you attend a conference, they get to see those skills at work. You see researchers presenting their findings, so you see how they communicate, and you'll see they will say they have made a publication, so you'll be encouraged to go and look around and see that publication. Yeah,
very, very true. So Adele, Kastori has told us about writing skills, communication skills. How was it growing up and learning in England at Sussex? What type of skills were available for you to learn while you're in tertiary education, other than the obvious training as a neuroscientist? So when it comes to these writing skills that Kastori has talked about and communication skills that he has alluded to, were these skills instilled in you? Was it easy to develop these skills whilst in university?
Excellent question. Actually, to even go a bit further back, I remember when I moved into tertiary education, from my high school years, we're really like pushed to write a lot of essays. Mm-hmm. Well, I think that is because a lot of the education system are still very English based. Okay. And I've seen that some friends that maybe didn't come from the English system really struggled with the writing essays, because they would write in a different manner. And then when they would come to the UK, so in an English system, they would really struggle to get the formatting right, even just the referencing. Mm-hmm. And for me, I was very lucky. Since high school, I had training, and the University of Sussex provided training. So they would see, especially in the first years, how to write, how to do an argument, how to write scientifically. But I know that hasn't been the case for everybody. So I completely sympathize with the thing that universities should help more in that factors.
Awesome. Back to you, Kastori. You had talked about communication skills, and then you later alluded to data analysis. Can you elaborate about data analysis?
Yeah. So as we all know, like data is becoming increasingly important in workplaces for decision making, including healthcare. So I think it's important for healthcare professionals, wherever they were working, they need to be able to have skills of analyzing data, starting with simple programs, even Microsoft Excel. In Africa, you might find students, some of the students are graduating and they are taking these things for granted, because there is no much insistence on grasping these skills. But actually the current job market needs ability to be able to use softwares like Stata, R, Python, because they are like data is coming, a lot of data is coming in our workplaces, and we need to be able to tap into its insight. So I think it's very important. But also even clinicians, even medical students who are practicing in the clinics, they have huge pools of data. If they have the right training in research, we will be getting a lot of publications from the clinicians, but the data is there, nobody is using it. But if they had the skills, they will see how juicy this data is, and they can generate a lot of findings which can be useful to make a change. Yeah.
Awesome. Awesome. So the data is there even for the clinicians to carry out various forms of analysis, but that's not happening. Harriet, as a clinician, where do you think the problem lies, or where's the problem? Is it in our education system, or do you think it's because we as students, or while we are students, we have challenges being able to learn these skills, maybe because of coursework? Where do you think the problem lies?
Well, that's a good question. I think Kasturi partly highlighted that. It's not like maybe in most African universities, it's not like we're not taught research, but then there is less emphasis on that.
Okay.
And, as students, perhaps we do not see a real-time application of that. It's like most people, research is like it's like a requirement for us to pass, medical school. But then with the clinical, it's like everybody knows that I will just finish medical school and then I'll go become a clinician, but I don't really see if I'm going to apply these research methods. And yeah, so I think that's where the problem actually starts. So there is a need, I think, as Kasturi explained, that being a clinician doesn't exclude you from being a researcher. And actually, if you're a clinician, you are seeing the problems and you have the research skills to go about using this data that you have, all these different cases of different kinds of patients that you see, then it can actually help to even generate something better, like bring about a good research proposal that can actually make a change in the clinical practice, other than waiting a person who is purely from the public health perspective to come and researching, in clinical medicine, for instance. So I think probably the way our training is shaped, it's like it makes us focus more into the clinical perspective and give very, very little emphasis on research, and therefore most of us end up ignoring this aspect. So I think we kind of need to put more emphasis on research and also as medical students, to also try to see this aspect of training as a very important part as well.
Okay, so it's our system that has made us to be more of clinicians than researchers, and research is a skill that we as Africans can embrace or need to embrace and learn from a very, very early stage in our careers as students. So then you were one person that actually developed these skills while you were a medical student. What was your driving force to being able to learn these skills? How is it that you stood out and learned these skills even when the environment was not particularly encouraging for medical students to learn such type of skills?
Well, this is a good question. And I think my very first statement was that, as a student, you have a lot of options. Just by going to medical school doesn't mean that you can only become a clinician. So the very first and foremost to me, which I think is important, is just to be open-minded, to explore all available opportunities that come, that you think you might become. So for me, being open-minded was one thing that really helped me out. And, it's about, well, you have your training, you have your coursework and other things, but then how are you engaging into these other skills that might actually, which do not seem really very important, but they're actually important. So I think it just needs, like medical students, I would say, or, students in healthcare profession to sort of put an eye, or sort of give more attention to this other aspect of the world, or other opportunities that comes along their training. So, as Kasturi explained, conferences happen every now and then. Attending them is one step that can make you realize that, oh, this is actually interesting. People do research. Oh, these are doctors, these are professors. Oh, so they're clinicians, but they also do research. Oh, people write grants, So just getting to actually take part in this kind of events, like participating in conferences. There are lots of seminars, symposiums, research trainings, Sometimes you don't really, sometimes I think that you don't have to be interested into something so as to take part. You can try to engage and then see if you might find yourself getting interested or not. So not just to say, this is not for me, this is not for me. Try to get into it. Try to see, like the other part of the world, and then you might eventually find yourself developing interest. But I also think it's important that the medical students also try to, like you list all these available options and then get to reach out to mentors or people that can actually help you think, in a way that can or sort of give you, like different insights about this whole health career, and so that you have a lot of options and you can decide on whatever you want. Yeah. So being out of the box.
So thinking out of the box and trying out new things is definitely a first step. And you have mentioned one point that you have mentioned that is quite interesting for me is reaching out to mentors. Adele, how available are mentors in the UK system?
Very much. It is almost scary. You can send them an email at 10 p.m. They will reply at midnight.
Wow.
So in that sense, I think I am very lucky. I know that it's not like that everywhere in all schools. It also depends on different mentors. But from my experience in the 2 universities I've been, they've been very, very cooperative.
So that's one real contrast. Harriet, do you think it's the same? Or let's shift on to Castori. Castori, do you think it's the same with our African universities? Do you think mentors are always readily available, as is the case or has been Adele's experience at King's College as well as University of Sussex?
Well, I wouldn't say it's they're not that readily available, but if you're lucky, they are really good mentors. You can find really good mentors. But again, you have to go extra miles so as to find them. They're not easy to find, but it's not that they don't exist. They're there and there are many, but it's just they are hard to find.
So they're
and
hard to
not
find.
all students have the opportunity to know how to find them, unless you are I can say you are outgoing, you like to explore, then you will find them, but otherwise it's difficult. Yeah, mentorship as if it doesn't exist.
So it goes back to the fact that you need to be intentional. As a student, you need to be intentional for you to get these opportunities, and you need to try out new things. Definitely, you won't get these opportunities if you sit idle. So our word or our message going forward, one lesson we can certainly put forward is that students in health institutions need to take the initiative to reach out to these mentors if they're going to be able to progress. How do you think mentorship has helped you, Harriet, to progress to the point that you have reached today?
I mean, honestly, I would say that if it wasn't, if I didn't get help by my mentors, maybe I wouldn't have met this step so far. So, I mean, we need mentorship. We need it so much because, I mean, because if we are expecting to grow, then if you are expecting to move from one step to the other, you need people who can actually sometimes show you the way, So, but also access to opportunities, like, I mean, as a student in the field of health, I would say that there is sort of a limitation. Like we don't, it's difficult for you to go out there and look for this opportunity and look for that and look for that. So our mentors are the ones who actually come across a lot of these opportunities. There is a research training. Oh, please, they would send it to you, apply for this. There is a grant, I think this is relevant for you, apply for this. You make the application. Sometimes you're not very good in writing and they would guide you through. Because I remember I have I have done a couple of scientific writings, but the way I remember the very first time when I was starting, at least, I mean, even for instance, just a recommendation later, the way I would write at the very beginning when I was starting, send it to my mentor for a review, I would have a lot of comments, lots of red marks. And then, you know, address them. Next time I write another recommendation later, fewer comments, until up to this point, I just draft a recommendation later, send to my mentor, and he just signs without making any correction. But
Wow.
then this is because, you know, it's been through phase and phase and phase. So we need these people to guide us. Even the way I would say I will do my writings in the past and how I'm doing now is different, because you will work with this mentor, you would see, so this time this is what I wrote and this were the corrections. So next time you would, you know, you would do something better. And I think it's also good that, you know, well, you can have one mentor, but it's good that you have multiple, like from different angles, from different perspectives, so that you also get to see, or like, you know, to get a different way of, you know, thought process, I would say. So I think we need mentors as much as we want to learn, as much as we want to advance in our careers, as much as we need to get into a lot of opportunities out there. We cannot do it by ourselves. So mentors are like, they are like part and parcel of the process. Yeah.
So yeah, Adele. So when it comes to you, how do you think mentorship has helped you to advance to the stage you are in your career? Right now, you are a master's student at King's College. How do you think mentorship has guided you to reach the current position as a student at King's?
It has made me, like, I got through with mentorship. And I completely agree that it is very important to progress. And I think that in my experience, at least, the system, we're always ingrained with the mentorship. So we have an academic advisor, a project supervisor, and just really our teacher always there to help us. What I've seen also through internships, for example, for me, through internships or through jobs, their mentors can be found in a lot of different fields. So it is obviously important to find them in the academic aspect, but can also be found in other places, and they can still relate to you and still show you, for example, opportunities that Harriet was talking about.
Lovely.
Well, they are absolutely very important.
Thank you so much. Kastori, finally, we'll talk about the opportunities or some of the places students can find different opportunities that fit their needs. So our topic really has been focused on them developing research skills, but then there are definitely other opportunities other than research that health students can find. Fellowships, for example. What are some of the resources that students need to look to or look at for them to access some of these opportunities?
Yeah, so I think it's important for students first to join professional organizations. If they are medicine students, they join medical association of their university, of their country. If they're pharmacy students, they do the same. If they are medical laboratory science, whatever profession they are, that will be the first starting point, and attend the events because those are posted. But unfortunately, there are not so many fellowship opportunities for undergrads, but still they can get opportunities through these professional bodies, like attending in public health campaigns. Those ones will help them to build skills, also to build networks, but also social media platforms like LinkedIn is very good. They just have to follow the right accounts. Twitter is also very good. They also need to follow the right accounts so that you can get information. For instance, the first event I attended when I was in first year, I learned it through it in Twitter, and yeah, it was a game changer. And then that was that. But also another important, there are these kind of events, innovation challenges. They are very, very important to get extra skills that are needed in the current century. But also, hackathons are very useful because they get to meet with students of other professions. Most of the hackathons, they tend to mix students from different careers. So
definitely,
yeah, those are the ones that I can Yeah,
So definitely, Castori, you're alluding to the fact that social media can be used for good and for learning purposes other than posting photos on Instagram. So
definitely.
you can use social media to expand your networks. You can use Twitter to learn of different opportunities, fellowships. I think I'm aware of different fellowships like a Mandela Washington Fellowship. And these are fellowships that can build students leadership potential, for example. I know both you and Harriet have been great leaders in the different aspects within you during your time as tertiary, during your time in as students in a tertiary institution, and definitely Adele has also done a fair bit in that regard. So I think we need to package our learning or transform our learning in such a way that not only do we try to reach out for mentors that are going to build us, but then we also leverage opportunities that are available in the public space, like fellowships that might be shown on social media platforms that most students actually have access to. Because I'm aware that most students have internet within their facilities and they will have some access to social media. So it's definitely a step that we can that students need to take going forward. So in summary, Harriet, what's your take-home message to people that or to our listeners back home today, our students back home? What's your take-home message regarding them building skills?
Yeah, so I mean, I mean, this has always been a statement, especially when I talk to so-called my mentees. So being, thinking outside the box, not just focusing on the training or the most emphasized aspects of the training, but also trying to see other opportunity, however small they might look or appear or unimportant, but trying to tap into those other opportunities that comes along our training and trying to explore how and see where they can take us. And to hunt for mentors, because sometimes if you don't show the initiative, you will stay there, especially in our contexts, like in Africa, where we don't really have well developed, mentorship programs. So if you don't take an initiative, sometimes you just need to go and speak to this person that you think, I think I wish to learn from this professor. So, taking the initiative to see mentors, asking them to be the mentors, and, thinking outside of the box and exploring all possible opportunities that come along, as long as they're relevant to the field to our field of interest. So I think I would basically say that.
Thank you. So Harriet's message is take the initiative and reach out to mentors. Castori, what's your message to our listeners?
Yeah, so this is comes from a mentor. He always said that the world is empty of skillful people. So I think if students out there, they develop the right skill, they'll never be jobless. There are so many opportunities out there that need to be tapped into. So people should not stop learning. They should learn as much as they can. There's so much to be done in this world.
Yes. So Castori's message is very clear. Never stop learning and you'll get there. Adele, what's your message to the listeners?
From a personal opinion, I agree with both. Go out there. There are resources, even just on your phone, that can be found, and through it get contacts, learn new skills, because skills are out there. You can find free courses online, and those are very important and very interesting. There's always something new to learn.
Yes. So thank you so much. So we really want to thank all three panelists today. And from me and the Health Careers Live team, thank you very much and see you next year.
Thank you.
My name is Shivani, and I'm currently a third-year medic at Barts in London. And today I am joined by 4 incredibly knowledgeable and experienced individuals. So the first person is Dr. Dipesh Gopal, who is a research fellow and GP based in London. We also have Kayode Oki, who is a medical student at Dundee. We have Christina Plowman, who is a medical student at UCL, and Khadija Migwawi, who is a medical student at Bristol. And they've all had extensive experience working in decolonisation medicine. And we're very, very excited to hear what you have to say. And we will also take any question at the end, so feel free to put them in, and if there's time, we'll definitely consider them. So I want to start off the panel by actually talking about what decolonisation is, because it's a concept that's been around for quite some time, but it's incredibly relevant today. So what does decolonising mean to you, and why is it so important?
Who wants to go first? Should I go first?
Yeah, go for it.
Okay. I would say decolonization is about disrupting the current power balances. So this cis heteronormative patriarchy that in which we live in, it's kind of like questioning who holds the power, who holds the knowledge, like what is even classed as knowledge. So I would say decolonizing is kind of like just an up yours to society and what the current practices are.
Do we know roughly when this is going to get started? I don't know if anyone's chairing the panel.
Hi. Hi, Christina. Can you hear me? Hello?
I don't think she can hear.
Oh, no. Okay. Let me message her. Just a minute.
I think that's all I had to say anyway. Just, I guess, questioning what is class and knowledge and who owns the knowledge. I'll pass on to someone else. Catch the metaphorical ball.
Hi, apologies, my audio cut. Would someone be able to repeat the question?
I can't hear you now, Dipesh.
Shivani, we can't hear you.
Oh, sorry. Hi. Khadija, the question was, what is decolonising and why is it so important in the medical curriculum?
Yeah, I mean, I was going to say that I think there seems to be an idea that medicine occurs in a vacuum, and especially like medical research is.
Oh, sorry, where are you going? Oh, sorry.
That medicine and medical research occurs in a vacuum, so it's like pure and it's free from outside influence. So if we look at like social sciences, politics, art, we know that definitely does affect medicine and the directions that it does go. I mean, and if you look at like psychiatry during like the civil rights protests in America, you know, people that were protesting were taken off the streets. And, you know, labeled with psychiatric disorders, which, you know, is completely an insane thing to do. And so medicine had like a way in like sectioning these people. And so the other thing is also that research is free from bias. And as soon as something is research, some people feel that it's pure. And, you know, it's conducted by humans who come in with their own gaze. Nothing is free from bias. When everyone says it's unbiased opinion, it's just, that's not a thing. And so decolonization is sort of looking at one of the aspects is looking at the way history, so colonization, and we are all products of that colonization, and globalization as a concept, but that has changed the way that medicine is going, and it's not always benefiting everyone in society. So it's about challenging power, like Oki said, but it's also about like looking at medicine in a completely different way. And when you challenge, we'll go into the experiences, but when you challenge people, they get upset when that happens. And so that's our role, basically.
Christina, can you hear us now? We can see you now.
I'm really sorry about that, and I'm sorry if I interrupted anyone.
Oh no, don't worry.
I don't forgive you, Christina, at all. I'm still seething.
So we were just talking about like what decolonizing is, just to give like the audience an understanding of it. So is there a way that you would define decolonization?
Yes, definitely. I'm sorry if I'm going to repeat anyone's what they've said already. I think what's quite interesting with decolonizing is that in its original usage, it was used for kind of repatriation of like indigenous lands to those indigenous people who have been colonized. So we do have to be quite sensitive with how we're using this. Oh, you can't hear.
It's just a bit quiet.
Oh, I'm sorry. I'll try and speak. Can people from the chat? Can you know? Well, I think it's the students who can't hear me. Can you hear me now? Annabelle, Maria, Sarisha. Okay, sorry about that. I will start again. I'm sorry if I'm wasting everyone's time. So it relies on the understanding of the historical impact of colonialism. So in its original form, it was about like repatriating indigenous land to people, and we have to be careful about misappropriating that. So in the decolonizing the university movement, it's more about decolonization of knowledge. It's just a method of deconstructing kind of complex and big social issues that are present in medicine and society, like how institutional racism can lead to like differential health outcomes that have been shown in like many different areas, like obstetrics, like COVID-19, but also it gives an insight on how to deal with this in like both a personal and professional way. So like shifting an emphasis from kind of just pure biomedicine to like medical pluralism, so including different kind of health narratives and models of health beliefs, like cultural safety, critical consciousness, things like that. But actually you can apply decolonization to so many different things, like arts and literature, sport even, like it's a very useful tool and powerful tool of analysis. Shall I go on, or did anyone want to add anything? Hello?
Giovanni is trying to say something, but we can't hear her.
We can't hear her.
Can you hear me now? Okay, I'm so sorry, so many audio issues today. I just wanted to say that's really interesting to see like the different viewpoints, like especially like medical pluralism and like different narratives. And I wanted to ask you all, how do you think we can kind of incorporate this into like the medical curriculum? I know that many of you have worked as part of that. So how have you been able to try and incorporate?
I've got a bit of a... Oh, sorry, I thought I had a lag, but I don't.
Hi, Khadija.
Hi. Would I be able to answer the first question?
Yeah, go for it.
Sorry. So, is someone getting a lag? Like an echo?
No.
Okay, I'll keep talking. I'm so sorry. I think that with decolonization, it has to be reframed as a matter of patient safety. So often we kind of view this issue as sort of like theoretical, or something that, you know, serves our interests in terms of becoming more cultured as doctors, which is important. But when the curriculum needs to be made us to be able to practice on the whole population that we serve in this country, and internationally as well. And that population is not just you know, white, male, middle class. It is everyone. And if we start reframing this narrative as needing our curriculum to enable us to become safe and effective practitioners for the entire population, then the question becomes far more important, and there is a need for safety and efficacy as future doctors to prioritize this conversation.
Thank you, Khadija. It's really important because taking into consideration decolonizing, it directly affects patients' outcomes if you're not mindful of all of these issues. And that's very true. So I know that you've all worked as part of like decolonizing the curriculum, not only in universities, but also student groups, and also in healthcare as well. So does anyone want to share like what they do and how they've gone about it, and maybe what challenges you faced along the way?
Did you want to go for that one, because we haven't heard a lot from
Yeah, sure. So something I did at I co-led the formation of the BAME MSG at Bristol Medical School, so the BAME Medical Students Group, and I did this after coming to the BMA Medical Students Conference and proposing a rider-in policy which said that we had to have BAME working groups at medical schools to input into future program planning. So then I went and co-led the formation of this group at Bristol. And this was about 1.5 years ago. So what was very interesting to see was that things moved a lot more slowly than they did now, which I suspect is because it's, you know, the recent movement has made it a lot more focused. And it's not that I criticize it as, you know, people jumping on the bandwagon of a trend, because it's always good to get more support when it comes. But I do, as I say, like I sort of as a priority, when, as I've said previously, it's a matter of patient safety. But anyway, we formed this group. This group was kind of like, the ethos of it was moving the conversation from discussion to action. So I sometimes find that a lot of meetings around this topic for the last, you know, few years before this, at Bristol anyway, before this group was taken up, sort of framed around, you know, the theory, like, what does it mean, and why is it important? But for me, it was very important to emphasize that we should already be on the same page now. We know it's important, and we need to move the conversation around what is actually going to happen on the ground to make this change. So we developed a set of aims, very specific. So, you know, things like, and very tangible. So things like changing images, but not just changing images, ensuring that decolonization and diversity and racial representation, so even using the word race as well, is integrated throughout the medicine itself. So it's not just an issue on Diversity Day, it's an issue throughout your medicine. So things like we said about, like, when you're teaching about diseases, teaching about the prevalence of certain diseases such as sickle cell anemia that are more prevalent in other ethnic groups. It's things like ensuring your cultural competency is assessed in. We did an event where we had an ear examination, and it was, right, perform this ear exam on a hijab wearing patient. So it's like, as you can see, you're testing the medicine, but you're also testing your ability to be culturally competent as a doctor. So we did all of this. I also ran a medicine event, which got over 80 people attending. And it was because we're working to kind of like integrate these things like throughout the curriculum. But with this event, it was kind of like a stopgap in terms of people who ensuring that they're kind of that they've at least been exposed to these concepts before. So we explored how even a lot of like not being exposed to these concepts can actually endanger patients. Things like that studies showed that women who are dealing with domestic violence often need evidence from their doctors about like the kind of like physical bruises and things that they've had. Not saying, of course, that all cases need physical bruises, but it's part of the evidence. And a lot of doctors were unable to identify these on patients with darker skin, which meant that these women faced obstacles in terms of submitting evidence of the abuse that they'd faced. So it's things like that that are directly impactful. And we explored all of these in the session, from things such as dermatology to prevalence of diseases to all the other issues I've mentioned. And we had Malone Mukondi speak, who's just incredible, author of Mind the Gap. Yeah, the feedback was just, you know, that it's just how have we not been exposed to this before? So yeah, this was our work was kind of like, again, direct action. And then since then, I've gone back to the BMA, and myself and another rep from another medical school have now created a national BAME working group across medical schools for students to come together and ensure that this work is that we share best practice, create a document of best practice on how to kind of like increase the racial representation in your curriculum. And we're going to hopefully like co-produce a document with the BMA about it to ensure that BAME students are being protected for their time in terms of like how they're inputting into program planning, and to put the emphasis on staff to decolonize their curriculums rather than the students to do it for them. Sorry, I've spoken for a while, but thank you.
No, that's absolutely amazing, Khadija, the amount of work that you're doing in this field.
Okay, I want to hear your story again. It's too good.
Go for it. I think you're on mute.
Yeah, so I think in terms of like work to do decolonizing, I'll start with a different story that Dipesh hasn't heard. So I do kind of remember during my final year of my last degree, I did my final year was on international health, and I remember we each had to like write an essay on a topic of international health that we wanted to do, and one of my course mates, I'm not going to say her name because for confidentiality reasons, she was a bit of a, what's the word I'm looking for? She didn't really mind rocking the boat too much, and she decided to write her essay on First Nation people in Canada and things, because she felt that was an area of the curriculum, an area of just living in the world that isn't really touched on. Like Canada is always looked at like it's this wonderful, beautiful utopia place. Oh, Canada is so lovely. And I read her essay and I thought it was really, really, really empowering. And because I didn't really, this sounds really, really stupid, but until then, it hadn't really occurred to me that First Nation people, some people call them Native American people, exist in Canada. I just thought it was sort of like an American problem rather than a North American problem about lots of people being displaced. But in her essay feedback, she got really troubling feedback from our lecturer, because in the essay, she cited stories from people who were First Nation individuals who had been through all the atrocities. And the feedback she got was, how do you know this is true? This is just people saying this. And I would say that was probably like my first proper experience with the idea of decolonizing medicine and like thinking about who owns the knowledge. After that, I've become more involved in doing stuff specifically with the curriculum. So I currently sit on my medical school's race working group, and that itself has a lot of problems. I'll hand over to someone else to talk a bit more, because I feel like I've spoken for a wee bit and I'd like this to be a bit of a conversation, so I'm not just like giving a long speech for a really long time. So over to you, Tina.
Okay, thank you, Oku. I think it's very interesting the example that you mentioned about Indigenous people, because that is something that we don't have in the UK, unlike America, Canada, Australia, New Zealand. And a lot of what inspired me actually was a model of cultural safety, linking to what Khadija was saying about patient safety, that was co-developed by healthcare professionals and Maori people in New Zealand. So as an example of like co-produced knowledge, which is kind of quite startling compared to what the kind of traditional like biomedical ways of producing knowledge. So just to make a little link there. In terms of what we're doing at our university, I think the big thing that I should mention is that we did a roundtable event where we had 8 medical students presenting about what they were doing at their universities. And just to emphasize that we're not all working under one banner. We have very different approaches, and because each medical school is different, we're all at different stages. It was just really amazing to hear the different work that was being done across the country, and that like decolonizing is just one way of talking about this, but actually lots of different groups share similar ideals. But it's such the problems that we're talking about, things like racism, things like social inequalities, everything, health inequalities. There's such big topics, and there isn't a simple answer. It's very important to have diversity of thought. So I will pass on to Dipesh just to keep things going, keep the conversation going.
Yay!
DJ, finally. Yay.
At last! Perfect. So
Right.
sorry, everyone.
No, it's fine. What was I saying? So yeah, experience of decolonization of medicine. So I think I read an interesting book, which I think probably many people have read, by Angela Saini, called Superior, which looks at sort of race and rise of race science, and differences between the races. And one of the things she highlighted was the blood pressure guidelines. So the blood pressure guidelines, you know, for anyone who ascribes to Afro-Caribbean descent, then they get a different blood pressure medication because they are inherently genetically or biologically different. But when you looked at some of the meta-analysis data, it just didn't make any sense. There was no significant difference in blood pressure response. And so I wrote, I think I saw something online, and then I wrote something with one of the cardiologists, and we took it apart basically and said that, you know, there's so many reasons why it's wrong, because, you know, a lot of us could have African or Caribbean ancestry. No one can predict whether that is, and, you know, people who look white or Asian or whatever ancestry you might think someone is, they may very well have that ancestry, so you can't really rule it out. And all these factors, and put it online, and got sort of a hailstorm of I wouldn't say abuse, but challenges from the question, which was very interesting. And so, I mean, there's one consultant dermatologist who I'm not going to name, obviously, but sort of just did sort of take me to task basically on it, and said, I'm not a hypertension expert, so I'm not going to debate the guidelines specifically, but after citing the national guidelines and imply they are at best discriminatory or at worst racist, is a very, very dangerous accusation, even though it's scientifically rigorous. So if there's no evidence, then why are we doing it is the question. So when you challenge people on the evidence, that people get upset and angry and sort of just say, you're not allowed to do this, and it's like, why not? It's not benefiting patients, it's not benefiting anyone, so we shouldn't be doing that, and we shouldn't be doing things that are harming patients. So essentially, we are denying anyone who ascribes to African or Caribbean ancestry ACE inhibitors, which we know are very good. They're very good at protection in diabetes, blood pressure. They're kidney protective, so they're fantastic. Mm-hmm. And same thing you can say with lots of biological markers, which are just based on very small sample size.
Can I just go on, Khadija?
I was just going to quickly say on that literally ties to the whole issue we've spoken about before, that the idea of patient safety, and that actually we have to really, in order to, the other issue around decolonization is we have to start very openly teaching our own sort of like racist legacy and colonial legacy of a lot of our medical knowledge. So unfortunately, for most of the practices of medicine in the West anyway, there's a whole other conversation about how actually a lot of medicine develops in the global South and the East, which we don't really talk about. But anyway, the medicine that developed in the West was often, as with most advancement in the West, at the expense of people of color around the world, at the expense of colonialism. And in the West, for most of its advancement, people of color were not considered to be important as patients. They were not considered to be part of the population that were worth, you know, saving or furthering the health of. They were just instruments in order to advance the science and the medicine for those at the top, who at the time were white people. So that's the issue that we have here. And the problem is, because research is slow, and also people don't really think about it much or don't want to really own up to it,
a lot of the research and medicine we have to this day builds on that colonial legacy, and on both the legacy of colonialism and the legacy of slavery. So when you're building on knowledge formed, you know, hundreds of years ago, based on that, you just build and build and build, and you are not looking back and questioning your own history. That means that stuff like this that, you know, Dipesh talked about today is happening. And I think the issue that we're having is a lot of the time medicine focuses on the science and not on the history of it, and doesn't analyze its own subjectivity. It presents itself as objective science, right? You know, even in medicine, when you do like history of medicine or arts of medicine, it's kind of seen as an extra, it's not important. But the problem is we do have to start analyzing our own history to look at the flaws in these concepts, because once you identify the flaws and you just turn around and say, no, this research was done incorrectly, was done in an exploited manner, you can then more positively go, okay, we've identified that issue, now we can actively work to tackle this. We can actively get people of color into research, get you know, participants who are co-researchers with you. It's not exploitative. You are empowering them through this, and you are addressing the gap that exists to then develop better, much more competent practice.
Like I was just going to like just add to what, well, kind of sort of counter what Dipesh was saying, because I do think it does benefit people to follow the guidelines and everything. It benefits cis, hetero, white patriarchy. It benefits like that entire system. People are not willing to relinquish that power because they believe if other people have power, that means they're losing something. So I that is why people, including that dermatologist, they're quite triggered by the article you wrote in the conversation, because they don't want to relinquish that power. Like you, as an Asian man, you have come to threaten the white patriarchy. So why should they be happy with that? That is a massive threat to them. That is them losing their power. So I think when I think about decolonization, I prefer to think about it as even more than changing the medical curriculum, because even when we change the medical curriculum, it is on the terms of the cis heteropatriarchy. Like these changes are only allowed to happen because they've said it. So unsurprisingly, Khadijah's work had a lot of progress because of recent events in the media. Prior to that, she wasn't getting any attention or anything, but because her medical school wanted to be seen to be doing something positive, they're like, yeah, I don't want to say, but they did jump. They are jumping on the bandwagon. So I think even when they are letting us do things, we need to keep on pushing and ensuring that sometimes actually students, we're the people who know more about some situations. So I'll come to a story later on in the conversation, maybe, hopefully. But I had a group called Seizing Your Curriculum with my medical school. And within that group was a student who is literally a trained anthropologist who has been out there doing field work, but she still wasn't taken seriously because she was a student. And the cis het patriarchy and white supremacy were up there, of the medical school were up there saying, oh, we know more and we know better. But actually, she was a specialist. She's done this for many years. But that's all I have to say on that.
I think, oh, sorry, you go, Khadijah. I can't hear you.
Classic. I was just going to quickly respond to that and say that's why it's about pushing beyond what the trend says and what has now been deemed acceptable. So I've even noticed this now in like a lot of the actions I propose. It'll be things like, okay, like now people have said we need to have some diverse images, so we're doing that. But there's still kind of resistance when you try and move beyond that and say, okay, can we, certain requests I won't necessarily name just because we're still in discussions about them, but when you try and like sort of push beyond what has been allowed or is the trend, that's when the pushback happens, or when you try and address issues that aren't necessarily being spoken about. that can happen too. So I just want to like tell healthcare professionals, medical students here, just don't be afraid to keep asking and keep pushing, and also ensure that you're being compensated for your time when you do that, because as I've said before, it's the staff's job to act on what like you as students feel you need, and that's why like we're creating, as the National BAME Medical Schools Group, we're trying to create this document of best guidance to show you how to protect your time, and how to form effectively as a group in your schools so that you can then make progress on this. But yeah, entirely literally echo what you were saying, that it's like a lot of it is to do with the trend, which is good, but it can sometimes mean that you are stopped there. So don't be afraid to go beyond that.
Yeah. Is my sound working?
Yep.
Okay, good. So I definitely think there are a couple of points in here that are like really important to look at. So one is this kind of hierarchy of knowledge that we have, that is within biomedicine, or as Khadija was talking about, like what's traditionally seen as like Western medicine, and these hierarchies of knowledge. So you might have seen like these kind of pyramids where you have like a randomized, a systematic review of randomized controlled trials at the top and anecdotal evidence right at the bottom, and kind of non-biomedical models are completely excluded from that. So when we start to learn medicine, we sort of kind of are enculturated into this knowledge system, and we have to be very aware that and be critical of this, which is something that the medical school don't really teach you, because you are given these facts about blood pressure guidelines, for instance, or about let's say like in renal medicine, like estimated glomerular filtration rate, for example, and you're not taught to question this at all, because these are facts and they are black boxed and they are removed from the knowledge system from which like produce them. In some ways, like with infectious diseases, if it's a simple bacterial infection, you have a guideline about the right antibiotic. That is kind of more simple and that seems to work. But what about non-communicable diseases? What about like mental health conditions and things like that? These are like big, complex, multifactorial things where medicine actually plays quite a small part in the overall health of that person and their lived experience. So doctors sit in between these two, like we sit between like the kind of the medical knowledge and also the patients and other healthcare professionals, of course, like nurses, physios, everyone like that. And to reconcile this really takes you to take time to be reflexive, to be critical of the system, and to be active in what you're doing rather than kind of passive and reactive to these guidelines that you could blindly follow. There are lots of different examples of this, like in a recent Lancet paper and a New England Journal of Medicine paper, they analyze kind of race-based medicines and race-based clinical algorithms that I'm happy to link for you to take a look at, of these examples where you just propagate these kind of taken for granted assumptions about the sort of things that we've mentioned. Sorry. Sorry, you go ahead.
And just like to add to what you were saying about like evidence and stuff, just a quick poll here. Oh, am I muted? Oh, can you hear me?
No, it's okay. I unmuted you. Don't worry.
Oh, okay.
Yeah.
But what you were saying, Tina, about like levels of evidence and stuff, like just a quick poll. How many of us have had to do more than 2 surveys to do with like race recently? Yeah. And like I've got like really serious survey fatigue. So whilst I've been sitting on my university's race working group, they're wanting to send out a survey to BAME students, and I've just been a bit like, but why? For example, the BMA have literally released long reports about the issues non-white students face at university, at medical school, but people are refusing to use that information. I'm literally sitting here as a black student telling you what these things are, but you're not using that information, but you want to do yet another survey because, I don't know, you want to do some sort of stats analysis that doesn't really mean anything. So I think that was a really interesting point on like levels of knowledge and levels of evidence and stuff.
Yeah, I entirely agree with that. I think sometimes, in a way, people would rather resurvey and re-find out what we already know because they want to distract, or not even deliberately, but they want to not focus on the action. I'm always saying move from discussion to action, because so many conversations around this just get lost in further conversation instead of moving towards, okay, we have a general consensus, what can we do? And this is why I believe in things like at the end of every discussion with BAME students, you should be showing some commitment to what you're going to do next, because you need to compensate students for their emotional fatigue of having to explain these issues again. And that isn't fair to students to continuously ask them for that input without showing the progress. So for example, something that really meant a lot to me actually was my medical school have now set up a medical anti-racism task force. As a BAME medical students group, we previously had a meeting with the head of our effective consulting actors. So we have, like, in medical schools, actors who go through, like consulting techniques with us, breaking bad news, all of that. And the data was shown to us. We were like, basically, the demographics are extremely white. The statistics were shown, like, literally 99% of them are white. And we were just sort of like, this isn't right. Like, obviously this isn't good at all. And then months, and this was sort of like pre-COVID, but then everything got put on hold. Then the trend came up. So then months later, I came to this new task force meeting, and the same person represented the data, and I was just ready to see no progress. But then actually they detailed, we have now devised a recruitment strategy, and we're now recruiting more actors of people of color and stuff like that, and presented that. And it just meant so much to me, like, to see that our feedback had been taken on board and actually actioned. But that rarely happens. Like, most of the time, it tends to just be representing the problem and getting more feedback on the same problem again. And then the other thing I just wanted to touch on is also this expectation that, like, BAME students have all the answers just because it's about race. For example, just because I'm a person of color doesn't mean that I'm an expert on race. I know a lot about it through my own reading and work in this as, like, chair of the BME network at Bristol, but I'm still not an expert. And what's even more worrying, but at least with me, like, I volunteer my time to be asked about this. I set up the BAME Medical Students Group, etc. But what was really troubling is that often in tutorials, when the question of racism and race is brought up, everyone just looks at the person of color to answer, which is just, an unfair stress and burden on a student just trying to learn. And that's why one of the actions we've done as, like, the BAME Medical Students Group is we've said, okay, we would like, in our effective consulting, just as you teach how to break bad news, how to deal with a difficult patient, we would like to be taught how to deal with a racist patient. We'd like to be taught, that question, what do you do if a patient refuses to treat you just because you're not white? To be treated by you. And in that session, we don't want that just to be a free-for-all discussion, because then what will happen quite naturally is, like, everyone sort of looks at the person of color. We want it to be taught by a facilitator in the same way that all the other things are taught, and some guidance and guidelines and, like, a mark scheme to be produced to say this is how you do it. So the pressure isn't on the student of color anymore. Because just like with discussions around breaking bad news, we can all maybe come up with suggestions about how to do it, but then there is a framework, there's a taught framework. Discussions about racism and being an anti-racist bystander need to be treated with the same level of importance, and that needs to be reflected in your mark schemes, in your assessment criteria. So that's one of the things we've insisted on as well.
Yeah, I completely agree. And thank you so much for everyone who's been posting resources in the comments. The audience are very grateful for it. And we have got some questions. That actually brings me on to my next question about, like, I think most of the people here are aspiring students or current medical students. And it's just like, what can they do to bring all of this, like, research or stats to action? So what can they do to learn more about decolonization? What can they do more to, like, spread awareness, like other resources are you guys aware of?
Do you want to go, Dipesh?
I was going to say, like, I thought Tina has all the answers with that amazing group.
Well, the first thing is that it's brilliant that you guys are here and you're showing up to a conference on a Saturday morning. I think that's really, really impressive that aspiring medical students are engaging with this kind of thing. And asking questions to us. That's brilliant. We have a Facebook group and a reading list, and that is full of resources which range from kind of academic articles to podcasts, books, films, documentaries that I have shared, but I will share again. But I think the most important thing is to be curious and to be open, to read more about it, be open to different points of view. And I think it's like a big part of that is to be, like have some humility in knowing that you do not know everything. Probably neither does the person that you're talking to, but that you're willing to learn, and you're willing to learn from that other person, even if you don't completely agree with them. But have some sort of constructive conversation, because people, no matter like what their backgrounds are or coming to it, what's really good is to cultivate an environment of like understanding where they're coming from. So that's what I would do at this level, at your stage. So do some reading, get involved in a conversation, have some constructive disagreements, because sometimes you learn a lot more from people who disagree with you than kind of being in the same environment where everyone seems to agree with each other. I'll pass Dipesh, you go ahead.
No, I was going to say, absolutely. I mean, I think the most important thing is you don't need to really win debates and things like that. I think completely what Tina said. I think you get polarization, and you have that in political discourse and economic discourse where you just have two poles and they just disagree with each other the whole time, but they're not really willing to see the other person's point of view. They just shut them down, or you say something and it triggers the other person and they shut you down. Like you're not allowed to say that. And what really is important is you just have to be open. You have to, I think if something annoys you, if you hear something from the other point of view, ask yourself why, go deeper, and then go deeper. Why of the why? Why does it annoy you? Is it because you have a bias against these people because that's the way you've been taught? And that's true. You might do, and no one's perfect. But that's not really the point. It's examine it. Once you examine and do the deep work on yourself, it becomes easier to examine the situation. You'll sort of get three groups of people. There'll be one group of people which you'll try and have a conversation with, you completely disagree with, and they don't want to hear anything. Anything you say will double down their point of view. You can't change that group. Then you have people who definitely agree with on the other side, and they will agree with you because you share the same point of view. These aren't the people to change. It's the ones in the middle. That's how you get change. And so that's what we're hoping, that people are open to having that point of view and wanting to challenge their own belief system.
Yeah, and just to like add to that, what Tina and Dipesh were saying, I think two things. First thing, in relation to what Dipesh was saying, my form tutor back in secondary school many years ago told me that I should never underestimate the power of arguments. He's a massive Tory, by the way, and and he told me, like, whatever you do, just make sure you always have your say. Like, even if the person is saying they don't agree with you, but if they have and they're just completely arguing with you, just say what you need to say and leave. But if they have like a brain cell, what you've said would have had some sort of impact on them. So don't put yourself in dangerous situations and say, hey, you racist person, I'm going to argue with you right now. But if it does come up, just say the way you see things, and you might be changed and that person might be changed. And then in relation to like Tina's points about like reading, so earlier I posted a TED talk about the danger of a single story, and I think that is so important. So I always say consume as much media from a variety of different sources as you can. So I'm a Black Nigerian, but I love musical theater, but also watch Nollywood movies. I love Bollywood movies. I used to even do Bollywood dancing. Like, just like consume media from lots of different places. One of my favorite things that the Decolonizing Med group did was they had like 2 sessions based on a TV series called Pose, and we were just talking about like the different issues that trans people face. So obviously we talked about it in a more academic context, but just watching the TV show on Netflix is amazing. Dipesh, if you search hard enough on YouTube, you'll see it. I went viral in Pakistan, just saying. That's it. Over to you, Khadija.
But it's hard to follow that one up, isn't it? What am I going to say now? But no, I entirely echo what everyone's just said. I honestly, massive props to Tina and the Decol group on Facebook. Check them out because they've got some amazing medicine-specific resources to educate yourself. But I also think obviously educate yourself and read, but don't put this pressure on yourself to think I have to become an expert in this before I can do something. You really don't. Like, obviously read as much as you can, but of course everyone's limited with their time. So I feel that now hopefully most people, and even by showing up here, you're on the same page. You believe racism is wrong. You believe that people of color deserve representation in medicine. Once you've got those 2 things in your head, that is enough to start acting whilst educating yourself. So I want to reiterate, it's things like I believe very strongly in getting involved in like trade union groups. So I recommend the BMA, like I'm involved in that. I dropped an article about the great work they've done in terms of like the racial harassment charter and putting that on the agenda of medical schools before the trend. The advantage to getting involved in a trade union or some sort of like activist group is that you can then mobilize and work with people nationally and who will help you remember that this is something that everyone is talking about and you have a weight of a group behind you to support you. And of course, hold that group accountable too. Like, don't just blindly follow, be like, no, you need to put race on the agenda, keep mentioning it. But when you have a group behind you, it gives you more power and numbers as well. And can also like empower you and give back to your time for getting involved. And I also think as well, just develop that zero tolerance. So just remember, and this is something that people can often make you forget, racism is not a debate. It's not a discussion. If a patient is telling you, oh, I just want a white doctor, like because like this, that, whatever, you know, reasons that are given, just echo. It's often really powerful just to echo things as guidelines to say, you know, the NHS adopts a zero tolerance policy to racism and discrimination, and we are holding up that policy. And you, as if you're a white student or a white professional, you being an active bystander can be such a powerful thing to the person of color who can be made really vulnerable by this. I once got told on placement, why, like, how are you studying medicine and you wear that on your head by a doctor? Like, a doctor said that to me, and it was pretty traumatizing, and they kept like, you know, back and forth yelling at me about it. It was really awful. And all I could, in that moment, I was trying to defend myself, and I looked around and I saw a couple of white nurses who were clearly shocked by it, but they didn't do anything. And I think they weren't really sure what to do. And if they had stepped in, I'm not like, you know, but they should have stepped in as active bystanders. So that's where, you know, if you're a white person, you're wondering like, what can I do to help? That's what you can do. You can step in with that zero tolerance. And if you're a person of color, just be empowered by that. Just know that, you know, trade unions and policy should be behind you and should be backing you. And also just like a kind of a quick amendment to say that as a person of color, remember also that you have a role to be an ally to. So myself, especially with this movement, I've been conscious that I'm not Black and there are specific issues that Black people face in terms of anti-Blackness. And I also have a role to be as well, like an active bystander. So remember all of those things and you can do so much, honestly.
I'm going to say, I think I was going to very quickly say, as a clinician, senior clinician, a GP, like if any trainee or any junior member of staff does say that, and it's important for me to step in. And similarly, if you're a medical student, then, you know, your junior doctor colleagues, your registrars, your consultants, if you don't feel comfortable challenging the patient, you should tell them and they should back you up without question. They are ascribing skin color or the way you look to your competency, and that is not appropriate in any shape, way, or form.
And I think what I find really helps is this is being recorded. I don't care. Is just make them feel really stupid. And just like repeat what they've said to them. Oh, so you would rather die than be treated by a black doctor. Like, I think just like echo, just repeat what they've said. And I think when people literally hear the words they've used, they realize how ridiculous it is. And obviously definitely flag it up and report it. So since last year, I've been doing this thing where I have a folder on my laptop called complaints, and I've just been, anything that happens, I literally just complain to university. Like, the head of HR knows me quite well now. She's tired of me, but it doesn't really matter. Like, just like, I've dedicated an hour of my week to complain, basically. But just keep on complaining, because that way then they can never ignore you. Just keep on using like their own systems, I suppose, in a way, against them as well. Just keep on complaining. Like, don't be afraid to complain. You're a student. You actually have quite a lot of protections. They can't actually really do much. Yeah.
Exactly. Sorry, I just wanted to really quickly add on something I'd forgotten as well. Definitely keep putting it on people's agenda by doing things like that, by complaining, by showing that you care. Even if nothing gets done, you show that this is important. And I was also going to say, just to bring up part of the conversation, not just about educating yourself and empowering yourself, but also on learning about specifically what to do next. So in terms of like learning how to, increase in your curriculum and improve education about this stuff as well, because what we're saying here, medical schools should be teaching. I would really recommend like talking to the BAME medical students at your school and yourselves even as white medical students, and forming some kind of group to change the curriculum at your medical school. If you want some more information on like best practice about how to do this, like please email me and I can add you to our like working group where we focus specifically on direct actions to change the curriculum. But the reason I want to always bring it back, well, it's not just the curriculum, but the school, but I want to bring it back to medical schools and medical education, is because the stuff that we're saying here should be taught content. And I want to help like empower students to do that at their medical schools as well.
So we're actually coming to near the end of this session, but are there any burning questions? I think we can take one or two. I haven't seen any. And also, I think you all have already, just drop your socials so that people can message you asking about questions, because I think you've shared a lot of resources. There's been a lot of food for thought in this panel. Not seeing any questions coming up right now, but yes, thank you so much.
We answered our own questions.
Yeah.
I think one thing, can you hear me?
Yeah.
So one thing that I think you sent to us that you want to discuss was what the future of decolonizing healthcare
yes,
would look like. And I mean, that's a really interesting question, because to sort of reimagine like a kind of ideal scenario or kind of utopia versus what we can like actually achieve is really difficult. And you're faced with the decision, like, do I want to working within the pre-existing system, or do we want to revolutionize? So when we talk with other decolonizing groups, like in other parts of the university, they consider us to be quite conservative, because we're working with the faculty and everything like that, and whereas our faculty sees us as quite like a radical group. So there are definitely like three areas that need to be worked on, like medical research, so what we kind of talked about with like the production of knowledge. So definitely as a student, look out for opportunities for you to get involved with research, and particularly if there's like crossover with any kind of social sciences, because I think that's a really exciting area or an overlap, or where kind of natural sciences and social sciences can overlap. In terms of like medical education, we're really trying to put together a toolkit that we can roll out to the faculty and lecturers, so that they themselves can start to critically analyze their own work and how they are actually teaching the medical students. Because we're not able to go through the whole curriculum and do that work for them, and like that has to come from each people individually. And the last one is like on clinical practice, and that's an area that like I'm not qualified yet, so I want to go into, but I definitely want to take these principles with me, and especially like from my position, I'm white, I'm coming from like, I'm going to be university educated and everything like that, so it's extra important for me to learn about these things and learn from you guys and everyone that I talk to make sure that I'm not actually propagating this idea of like the systems of biomedicine that we've been talking about.
And just to like add to what Tina's saying about learning, so like I guess my future of decolonizing healthcare, it looks obviously less paternalistic, but also just like recognition that other people have knowledge. That's one of my pet peeves about medical students and doctors and stuff. Like we think we know everything, when in actual fact we don't know everything. There are multiple knowledge holders, and there are like multiple truths, and just understanding that if, for example, I'm interested in widen participation, cool, it's good that I'm interested in that, but there are some people whose life's work is literally being an economist working in that particular sector. So I guess my ideal future of healthcare would be a health system in which we recognize and appreciate everyone's specialisms, everyone's knowledge, regardless of whether it's you're a doctor, a nurse, a physiotherapist, just genuine multidisciplinary work.
Yeah, exactly. And you recognize that multidisciplinary work, you then begin to realize that science and medicine is not objective, it's also subjective, just as literature is, just as history is. So you can then begin to analyze the things you're being taught and question what you're being taught and question its legacy. And in our case, it's often racist legacy. But when you do that, when you question, just always, as I've said multiple times, action, action, action. You've questioned, you've discussed, what are you going to do now? And that can be something you do individually. So you can then decide, okay, based on this conversation, I'm going to go and read this book or read this resource. I'm going to maybe, contact some BAME students and form a group, or like email my lecturer or something like that. It can be, what you do as a group. So you can form a group, you can lobby on this, generate some aims, etc. And then what you do, and then it's about what institutions do, what do schools do, and keep putting that on their agenda. So just be really, really careful sometimes, because there is so much performatism. There'll be, a statement about we are, our BAME students really matter to us, or we are continuously discussing this and reviewing this. But you just have to really cut through and think, no, what is actually being done? What is the tangible change? And put deadlines on that as well. And I think that's what I'd see in an ideal world. I would see, I'm not going to say that it would be perfect and that everything would just be equal and decolonized and representative, because that is very, very hard. Just even as a person, you're always having to re-educate yourself and find flaws. But in an ideal world, I'd want to see commitments to these discussions. I'd want to see timelines on these, and I'd want to see deadlines for actions. And I'd want to see BAME students and students of color being compensated for the time that they give to this and the energy that they're putting in, and people not to be shy for, just being unafraid to exist in the space that they deserve.
That's amazing. And have you guys been reading the comments? They're so lovely. And I think a lot of aspiring students have been really inspired by everything that you said today. And the comments just keep coming through. I think there's a really sweet one, which is, as an aspiring student, it means so much to know that there are people fighting for change. And it's just so sweet. And I'd like to say as well, thank you so much for giving your valuable time, especially on a Saturday morning or afternoon now, to come and talk about these important topics and spread awareness of this. I think we're ending the panel now, but thank you so much again, and thank you to everyone who tuned in.
Thanks for having us.
Take care.
Thank you so much for having us.
Thank you so much. It was an honor. Thank you.
Hello, my name's Marie Gabriel, and I'm here today to talk to you about potential careers all aimed at tackling health inequalities. I think the first thing I should do is tell you what I do. So I am what's called a chairperson, and a chairperson is someone who is appointed to lead the board of an organisation. And the board of directors of any organisation are the team of the most senior people who set the strategy and priorities and make key decisions on how services are delivered and resources are spent. Ultimately, we are accountable for the organisation's success or failure. And I'm chair of 3 different organisations: the NHS Race and Health Observatory, the North East London Integrated Care System, and Norfolk and Suffolk Foundation Trust, which is a trust and organisation that delivers services for people with severe and enduring mental illness. And within each of those roles, I have a focus on tackling health inequalities. At the Race and Health Observatory, we focus on tackling health inequalities between Black and minority ethnic communities and the wider population. In North East London Integrated Care System, we're a partnership of 8 different boroughs and all the health and social care organisations within them, and the voluntary sector and the local communities. And together, we improve services, but we also tackle health inequalities between different communities within our geography. And finally, at Norfolk and Suffolk Foundation Trust, we're really keen to address health inequalities because people with severe and enduring mental illness die up to 20 years earlier than their neighbours who don't have a mental health condition. So what are health inequalities? So health inequalities are avoidable and actually unfair differences in health across different groups of people within society. And health inequalities exist and are drawn from the different experiences and conditions that we live in, that we work in, and because of our personal characteristics, whether we're women, of our age and our gender. And these conditions, different conditions which we live and work in, or who we are as individuals, provide opportunities to actually have good health. So they actually influence the way in which our health is likely, health outcomes and the health that we experience. And they also actually shape the way in which we think and feel and act. So there's a diagram now on the presentation slide that shows you the different things that impact on people's health and health outcomes. And in the middle, there's a red circle, and it talks about your personal characteristics in that circle, your age, your gender, your general health conditions, those kinds of things that are individual to you. The second thing that impacts on health inequalities are the things that you choose to do, your lifestyle factors, whether you smoke, for example, and your diet and your exercise. The yellow arc is about your networks. So one of the things that's really important to keeping you well and healthy is actually having very strong social networks, being an active part of your local community and having really good friendships and support networks. The wider green arc is all about your living and working conditions. So your kind of work environment, whether you're working at all, the kind of education you have, whether you live in urban or rural areas, and wider things such as having clean water. And finally, the curve, that's the purple curve, the lilac curve that's on the outside, talks about actual other factors, the social, economic, and environmental conditions in which you live in. So, for example, whether or not you have enough income to survive, whether or not you're poor or have the means by which to access healthy food, whether there's anything in terms of the culture with which you live that favours certain foods that are unhealthy, or whether you live in an area of high pollution. And what happens is these factors together, people will experience them differently, and this will have an impact on their health and well-being. So just to give an example from the Race and Health Observatory, this is an infographic that we developed that actually describes some of the differences in health outcomes between Black and ethnic minority communities and the white communities that exist in the UK. So, for example, if you think about Black women and Black women who are pregnant, they are 4 times more likely than white women to die in pregnancy or childbirth in the UK. If you think about your Black African and Black Caribbean people, they're more likely to be subjected to community treatment orders than white people. These are sort of a way in which people with mental health are supported and actually required to participate in mental health support. And if you think about the South Asian community, they have a 40% higher death rate from cardiovascular heart disease. So when you look at this infographic, you see there's a range of different experiences, and all of these can't be explained by the individual's actual personal characteristics, you know, that they are a BME member of the community, Black minority ethnic member of the community, and they also can't be explained away by the conditions that people live in either. So there's a range of reasons, but also a really clever person called Professor Michael Marmot actually identified that a person's ethnicity is also a kind of precursor to the wider determinants, the actual wonderful rainbow I showed you, in terms of the health outcomes that you can expect. One of the things that you'll hear about if you decide to pursue a career in tackling health inequalities is what's called a population health approach. And this is an approach that brings together 4 overlapping circles, as you can see in the diagram. And what that does, it actually brings together the need to improve physical and mental health outcomes and promote well-being across an entire population by looking at the wider determinants that I spoke about in the nice rainbow, but also the way in which you act as individuals, but also doing stuff to intervene in terms of the communities and places. So thinking about how you can make sure there's good housing for everyone. And the 4th area that we want to bring together is the way in which we deliver services, so that we integrate the services that support individuals that have a healthier lifestyle. So what kind of careers can you have that involve tackling health inequalities such as these, that really help individuals and whole communities to have better life chances and to live longer and healthier lives? Well, actually, there's a whole range of careers, and they're in different sectors. So there's a public sector where you can work, and that's local government, the civil service, the NHS, and higher education institutions such as universities. You can also work in the private sector, for example, private companies and organisations and consultancy firms that would use people who have public health, which is the area of career that you would be working within if you're working on tackling health inequalities, to help provide advice and support and guidance and to provide information to organisations tackling health inequalities. And finally, there's a whole range of employment opportunities within charities and voluntary organisations and social enterprises. The range of careers, as I said, is exceedingly vast, and so therefore are the range of entry requirements. But I've just given you, over the next 2 slides, a sprinkling of examples of the sorts of careers that you could have if you decide to work in a career tackling health inequalities, or in public health, as the official term is. The first of which is as a volunteer. And there's, at the moment, there's been an explosion in volunteers who are working in trying to support people in accessing services in relation to COVID, and quite often called COVID champions, people who are trying to persuade members of their community who they know well or know about well to think about having a COVID vaccination. And this is a really good way to get started in a career in tackling health inequalities. And it's really about supporting people to access services to tackle the health inequalities they're experiencing. Probably the next level up is a worker that actually has a bit more knowledge of the key kind of facts and approaches and behavioural change processes that you can employ to help people lead healthier lifestyles. An example of this is the smoking cessation worker, somebody who really understands the impact of tobacco, but also understands how you can support an individual to change the way in which they behave, to be able to move away from a habit that's dangerous to their health. A key area in public health and in tackling health inequalities is actually understanding data, understanding information and insight. And this is really key to tackling health inequalities. So we need to understand what health inequalities exist, how they're experienced by different people, different communities, and actually what evidence we have that the approaches we're taking are really addressing those health inequalities, those unfair differences between different communities. And one of those roles is a public health analysis. It's people who sit there with all sorts of different figures and facts and bring that together to provide people with recommendations. There's also a role around an epidemiologist, which is a rather long term for people who understand disease and how disease impacts on communities and how that can be controlled. So public health is also actually about disease control. So if you worked, for example, in vaccinations, for childhood vaccinations, as a health worker, that would actually be involved in public health, tackling health inequalities. Oops. Other careers that are involved in tackling health inequalities include clinical roles such as nurses, and an example is a school nurse whose key objective is to keep children safe, healthy and ready to learn, and they work with a whole range of other people to support young people and their families. Their midwives will support mothers to stop smoking, and district nurses are nurses that go into people's homes and they help people to manage long-term conditions such as diabetes or heart disease, and to prevent those diseases becoming worse, or those conditions becoming worse for that individual. Quite differently, you may not have thought about this, but environmental health officers are a part of the wider public health workforce, helping to tackle health inequalities. And what they do is they assess and control factors that could have a poor impact on someone's health or community's health or cause diseases. And they usually work in local government. You might know them because you might see scores on the doors of your local takeaway, and they'll give them a score for the hygiene in restaurants, because you could have an outbreak of food poisoning if there's not good hygiene. And the final example I'll give you is the Director of Public Health. This is a very senior role that will have a responsibility within a local council to develop the strategy for tackling health inequalities. And within that strategy, they're going to be accountable for making sure that there are all sorts of measures in place to tackle the wider determinants, things like housing and employment, but also the individual lifestyle factors of individuals in actually the differences and working on the differences between communities and how we can help certain communities who are not having as good as health outcomes improve those health outcomes. And they're very senior roles. And I just wanted to, I just wanted to show you the board at the Race and Health Observatory, which is one of the boards that I chair, and to just give an example of the different people who are working within health. So within those pictures, there are a couple of lords. One is Victor Adibowale, whose background is working in the voluntary sector in an organisation called Turning Point, that work with homeless people. And a really great part of their work was reducing the poorer health outcomes for people who are homeless. There's another one called AJ Karkar, who's also a Lord, who is a clinician by background, very interested in the different health outcomes for people who are seeking support from health services. There's a couple of professors there. There's Professor Mike Marmot, who's very famous and has written very important studies into health inequalities and what causes them, and actually has informed governments about national governments about what changes they should make. There's also a couple of people there who are nurses. So there's Dame Donna Kinnear, who is a nurse by background and started out her career tackling health inequalities. And there's other clinicians. For example, we've got Chan, who is a GP by background and very interested in how GPs can support their patients to address the health inequalities that exist and improve health outcomes for themselves. We also have James and Stephanie, who are academics who research and build evidence and recommendations about how to tackle health inequalities. And finally, we have a chief executive of a NHS organisation, and we also have Professor David Williams, who's an international academic specialising in tackling health inequalities, and Dr. Kevin Fenton, who maybe people will recognise, he's on the top row at the end, who's quite often on television talking about the health inequalities that have occurred because of COVID. So as you can see, there's a breadth of experience and knowledge that's coming together. And I should have mentioned, we also have Alima, who is from the Chief Executive of the Runnymede Trust, a voluntary organisation, and John Appleby, who's a health economist, so looks at money and health and how you should use that money to promote good health. So, there's such a range of careers. I was trying to think about what type of skills would you need? So one of the things that you do need to be able to do is analyse and interpret information about people and their health and the differences on that within that. You have to be able to or enjoy actually reading a lot. So lots of literature and information on what works and what makes a difference, and findings from the academics that I was talking about earlier. You also have to be really good at communication. So you have to be really good at communication because you've got to work in partnership with a lot of people. So if you're a director of public health, you're going to be working with local government, with the NHS, with private businesses, with a voluntary organisation, and with communities. But also you have to be an effective communicator because you're trying to persuade an individual to change their behaviour so they have better health outcomes. And you have to have really good written skills to be able to present reports and write plans for action and change. So this means that you should really be doing courses that will help you develop knowledge about different health needs, what influences people's health and well-being, and how you can prevent ill health and how to promote good health. And there are specific courses that you will do for the whole range of actual examples that I was giving you earlier about careers in public health or in tackling health inequalities. So why would you want to work in a career tackling health inequalities as someone who spent their life thinking about how they can promote equality and social justice and eradicate areas where people end up having a worse outcome in life, whether that's in education or employment and health? I think really is a career where you can make a huge difference. You can work with individuals or whole communities or whole boroughs of people to help them live and have healthier and longer lives. And it's really good to be able to see the impact of your work. There's nothing better than helping people have a better life. And you can work with whole populations and helping those whole populations. You know, so if you're living in a London borough or within a county council area, you can be working with that whole community to help people stay healthy and keep them protected from disease and to help them reduce the health inequalities that they experience. I think you have a range of places that you can work. So you can work within voluntary organisations within the community, you can work in local government and councils and NHS, but you of course also can work in the private sector or in the academic sector, or actually within government departments nationally. And it's a really good career for thinking about how you can progress and how you can go up the career ladder. And in most of those settings, there's really are good terms and conditions. And finally, it's a career where you can work locally, regionally, nationally, or as I showed you with Professor David Williams, internationally, on creating a change for communities, not only just at home, but across the world. Thank you so much for listening to my talk today. I really hope you give serious consideration for a career in tackling health inequalities within public health. You won't regret it, I promise you. Thank you.